Welcome to our Diabetic Mellitus Workshop 2021. Good day to you. I am pharmacist chjenjen from the Diabetes Medication Therapy and Adherence Clinic team in Hospital Teluk Intan. I will share with you some of the common pitfalls that often happen among our patients and how we could manage them. It depicts the journey of our diabetic patients in achieving their targeted HBA1C. It requires a strong, multidisciplinary team support to help them reach the peak. Every patient has their own mountain to climb. That is, their own individualized HBA1C targets. A well-controlled HBA1C is a translation of an effective and successful collaborative effort from all disciplines. A poorly controlled HBA1C is just the tip of the iceberg of more problems beneath. It is our duty to troubleshoot the root cause that has been impeding our patients from achieving their desired HBA1C. A complete list of individualized targets HBA1C based on the patient's profile could be obtained from our latest Diabetes Mellitus Clinical Practice Guideline 2021. In line with our latest CPG guideline, our aim of treatment for diabetes is to improve quality of life, reduce complications, as well as to prevent premature death. Most of the macrovascular complications of type 2 diabetes are closely related to the degree and the length of the exposure to hyperglycemia. The effect or metabolic memory of early glycemic control is well established in reducing both microvascular and macrovascular complications. This should be emphasized in all patients who are newly diagnosed with type 2 diabetes. Multiple risk factor reduction of long-term complications and mortality is sustained beyond the intervention phase. And it is just as simple as A, B, and C. A is for HbA1c, B for BP control, and C for cholesterol control. The earlier the patient could achieve their desired HbA1c control, the better memory the body has towards a good diabetes control. It has been shown that earlier combination medication therapy, which leads to a better glucose control, delays the time to secondary failure by 26%. This is the power of legacy effect. Data extracted from the 2019 Diabetes Clinical Audit involving 181,000 type 2 diabetes patients, only 32.4% of the patients achieved HbA1c below 6.5%. What happens to the rest of the 133,000 patients? Can we do something to help them achieve their desired HbA1c? Patients, are you ready to work towards your own target HbA1c? We from the healthcare providers are ready to walk hand in hand with you through the difficult yet rewarding journey. There are 6 types of diagnostic tests to measure the blood glucose in our body. Fasting blood glucose is performed following a minimum 8 hours overnight fast. 2 hours postprandial glucose is performed 2 hours after a meal is taken. Oral glucose tolerance test is done in the fasting state by ingesting 75 grams of glucose. Patients should rest throughout the test and only allowed to drink plain water. Although OGTT is the gold standard in diagnosing type 2 diabetes, it is known to be poorly reproducible and cumbersome to perform. A standardized HbA1c assay has been shown to have the least variability compared to the fasting plasma glucose and the 2-HPP. Using HbA1c is convenient as it does not require patient to fast or consume glucose, and it can be carried out at any time of the day. HBA1C was found to give an acceptable sum of specificity and sensitivity of 97% and 42.5% respectively in diagnosing type 2 diabetes among all three major ethnic groups in the country. If HbA1c is used to diagnose prediabetes, it is best that the test is followed by OGTT to classify individuals into impaired glucose tolerance, impaired fasting glucose, or the combination of both.
Despite standardization, sometimes measured HbA1c value may still at times not reflect the true level of glycemia, which we refer to as glycation gap, due to various causes.
National Glycohemoglobin Standardization Program has published a list of HbA1c methods and any possible interference.
It is important to recognize the occurrence of a possible glycation gap and in what circumstances this may occur. Other methods of measuring glycemia in this situation should be considered. Fructosamine is the compound that results from the reaction between a fructose and an ammonia or an amine. Fructosamine estimation could be used as an alternative to HbA1c. Although the evidence is not as strong as HbA1c, it does reflect a glycemic control over the recent 2 to 3 weeks. Other limitations of HbA1c are that it does not provide information on glucose variability and does not capture hypoglycemia. In such circumstances, a combination of SMBG and HbA1c is appropriate. SMBG, preferably quality controlled, capillary glucose profiles is the most ideal and practical. SMBG is the method of choice in assessing glycemic control and preventing hypoglycemia. As part of the educational initiative, SMBG should be recommended in patients treated with insulin and is desirable for those on OGLDS. Frequency and timing of SMBG should be tailored based on the patient's needs, including glycemic status, drug therapy, treatment goals and lifestyle, dietary patterns and level of physical activity. Re-evaluation of the need for and frequency of SMBG should be performed by healthcare providers during each follow-up visits. Ideally, SMBG should be performed on a daily basis in people with insulin-treated type 2 diabetes or, if possible, at least one 24-hour cycle on a weekly basis. There are circumstances whereby a falsely high or low reading is obtained depending on the time of injection, meal intake, and the time of checking. We could counter-check this by doing a stat DXT and cross-check with HbA1c. Some of our patients are also taking other medications such as steroids, antipsychotics, or birth control pills. These medications could raise the blood glucose levels in their body. While some other patients who are on iron supplements or taking Dapsone could falsely reduce their HbA1c levels. Some of our patients are taking beta blockers, which could mask the tachycardia effect of their hypoglycemia symptoms. This could lead to hypoglycemia unawareness. However, in this kind of patient, we could teach them to recognize some other hypoglycemia symptoms such as sweating and hunger pangs. Hypoglycemia unawareness occurs when the ability to perceive the autonomic warning symptoms is either diminished or lost, such that the first sign of hypoglycemia is confusion or loss of consciousness. Recent or recurrent hypoglycemia can decrease normal responses to hypoglycemia and lead to defective glucose counter regulation and hypoglycemia unawareness. Hypoglycemia unawareness increases incidence of severe hypoglycemia and therefore should trigger re-evaluation of treatment regime. Both hypoglycemia unawareness and defective glucose counter regulation are potentially reversible. Patients should be advised to temporarily relax their targets. Strict avoidance of hypoglycemia for up to 3 months has been associated with improvement in the recognition in severe hypoglycemia. the other regulatory hormone responses, or both. We could look out for the signs of weight changes to detect hypoglycemia unawareness, as some of the patients could have defensive eating by taking double portion of food or snacking. Efforts should be given to patients to educate them to be familiar and be able to recognize their signs and symptoms of hypoglycemia and to manage their signs and symptoms the appropriate way. Some of our patients do not exhibit the usual signs and symptoms of hypoglycemia. It is best to check their glucose levels using a glucometer at the specific time. Hypoglycemia is defined by either one of the following three conditions: low plasma glucose level, presence of autonomic or neuroglycopenic symptoms, and it is reversed by carbohydrate intake. The symptoms of hypoglycemia autonomic response includes trembling, palpitations, sweating, anxiety, hunger, nausea, and tingling sensations. Neuroglycopenic responses includes the difficulty concentrating, confusion, weakness or stroke-like symptoms, drowsiness, vision changes, difficulty speaking, headache, and seizures or coma. Hypoglycemia are classified into three groups. The first group is between 3.9 to 3.0 millimole per liter, where it is recognized as a threshold for neuroendocrine responses to falling glucose in people without diabetes. For a plasma glucose below 3.0 millimole per liter, it is a threshold where neuroglycopenic symptoms begin to occur. It requires immediate action to resolve the hypoglycemic event. Any reading below that is a severe event characterized by altered mental and/or physical functioning that requires assistance from another person for recovery. The aims of treatment of hypoglycemia includes detect and treat low plasma glucose level promptly, eliminate the risk of injury to oneself, relieve symptoms quickly, and avoid overcorrection of hypoglycemia, especially in repeated cases, as this will lead to poor glycemic control and weight gain. Once hypoglycemia has been reversed, patients should have their usual meal or snack that is due at that time of the day to prevent recurrent hypoglycemia. Evaluate cause of hypoglycemia and educate patients on how to prevent future episodes of hypoglycemia. Diabetes treatment on OGLDS and insulin regime may need to be reviewed and adjusted. Risk factors for hypoglycemia includes advancing age, severe cognitive impairment, poor health knowledge, uncontrolled type 2 diabetes with glucose variability, hypoglycemia unawareness, long duration of insulin therapy, renal and hepatic impairment, and peripheral and autonomic neuropathy. Patients at risk of hypoglycemia should be discouraged from driving motor vehicles, cycling, swimming, or operating heavy machineries, as these activities may endanger oneself and the public. Patients at risk of hypoglycemia or with high risk should be educated to recognize and prevent hypoglycemia. Undetected nocturnal hypoglycemia can promote hypoglycemia unawareness, blunt counter-regulatory responses, anxiety, reduced quality of life, increased treatment costs, and negative outcomes such as falls, accidents, and arrhythmias. Risk of nocturnal hypoglycemia is higher, especially in the elderly. The clinical manifestations may include poor sleep quality, vivid dreams or nightmares, wakes with chills or sweating, chronic fatigue, morning headache, mood changes, nocturnal convulsions, and morning hyperglycemia. To reduce the risk of asymptomatic nocturnal hypoglycemia, individuals on basal insulin therapy should be periodically monitored early morning, 2 to 5 a.m. corresponding with the peak action time of the basal insulin plasma glucose levels. Alternatively, patients on sulfonylureas could adjust their dose or consider switching to an OGLD without hypoglycemic risk. Patients on human basal insulin could also be switched to basal insulin analogs. Both rebound hyperglycemia and dawn phenomena results in hyperglycemia in the morning. The main differences between these two are the glucose level in the middle of the night. Rebound hyperglycemia will have an episode of hypoglycemia between 2 to 5 a.m. indicating an overdose of basal insulin which require reduction in dose or switching to OGLDS that does not cause hypoglycemia. Dawn phenomena, on the other hand, will have high plasma glucose between 2 to 5 a.m. indicating an underdose which require an increase in basal insulin. Relative hypoglycemia is not a true hypoglycemia. It is a condition whereby the glucose levels are lower relatively to patients' usual plasma glucose levels and patients develop symptoms of hypoglycemia. Upon checking, their plasma glucose levels are usually very high. Usually, patients will mistreat as hypoglycemia by ingesting carbohydrate, which will only lead to higher plasma glucose levels. Psychosocial barrier remains as one of the most difficult barriers to overcome as it requires effective communication skills and plenty of time. There are patients who are in denial that they have been diagnosed with diabetes and in denial that their blood sugar control is poor. Some of them believe on alternative treatment more than the conventional medicine that leads them to abandon the treatment given to them altogether. Patients who are on complementary or alternative medicines needs to be counseled on side effects, drug interactions, and lack of standardizations in their alternatives. Patients who gave up on treatment due to demoralization should be counseled on complications and disease progressions, letting them see the benefit of HBA1C reduction as well as review on their treatment regime to optimize or intensify where appropriate. Poor past experiences can lead to fear or anxiety, which could further lead to overreaction by doubling meals or medications. For this group of patients, we need to counsel on hypoglycemia and hyperglycemia management. Some patients are afraid of injecting outside the house due to fear of being shamed or ridiculed. Diabetes can also cause distress in some patients to a point that they lost the ability to cope with self-care. Patients who have suicidal thoughts should be referred to the respective team. Loss of job or poor economic reasons can cause financial strain among some of the patients. They could be purchasing own medications previously, but due to sudden cut in income, they may refuse treatment altogether. Poor compliance is another big reason why patients are unable to reach their target HBA1C. Pill burden can lead them to self-adjust their medications by alternating their intake. We could switch them to combination drugs or give them a pill chart as well as counsel them on legacy effects. Some medications require special teaching such as the insulin. Some patients face difficulty in administering the medications as instructed. A thorough counseling on dose frequency, indication, and timing of medication administration, as well as the insulin injection techniques to the patient and, if possible, their caretaker or family members could be very beneficial. Reminder charts and diagrams could be given to serve as visual reminders at home. Some patients are forgetful both in taking their medications on time as well as bringing the pills or insulin together with them when they go out. Some of them worried about leaving their insulin in the room temperature. A pill reminder or an alarm preset in their mobile phones or calendar can help remind them. A standby dose can be kept in their wallet or workplace in case they accidentally left their medications at home. Insulin that has been opened is good up to 28 days and is completely safe to bring about during short outings. Some patients experience unpleasant side effects such as gastrointestinal discomfort or hypoglycemia, which deter them from being compliant. In this case, the root cause of discomfort needs to be verified and treatment regime to be reviewed and adjusted where deemed necessary. There are also patients who become poor compliant to their medications due to psychosocial barriers such as denial, fear, and anxiety. Some becomes demoralized and lose faith after many years of treatment, yet does not see or feel the benefit of treatment. This is the group of patients who becomes frustrated with the disease, for the disease only worsens over time. Early combination treatment will be able to overcome this barrier. Some patient has peculiar belief that they will develop dependency on their medications and insulin and that they will die upon insulin initiation. Some claims that medications will damage their end organs, hence they will try to avoid taking their medications. We need to educate this group of people on the right belief and consequently counsel them on disease progressions, complications of the disease, and benefits of legacy effect. Patients avoid insulin injections due to fear of needle and pain. This could be easily overcome by correct insulin injection technique and by allowing patients to try self-injecting to overcome the fear. Another pitfall lies in the delay of optimization and intensification of treatment. The barrier can happen to both healthcare providers and patients themselves. The fear of side effects, lack of confidence, and lack of knowledge, and the long gap between appointments deter the treatment regimes to be optimized and intensified as quickly as it should be. A shorter gap between appointments allows healthcare providers to optimize and intensify their treatment regime more frequently and more aggressively with minimal side effects risk. Besides, patients who does self-adjustment of insulin based on their own SMBG at home will be more confident to do so as the gap between appointments are shorter. This will allow patients to achieve their target HBA1C or well-controlled blood plasma glucose at a shorter duration of time. This will lead them to feel more confident towards the treatment regime given by our healthcare providers, thus are more willing to follow the instructions by our healthcare providers. This is because the earlier patients could achieve their well-controlled plasma glucose and their targeted HbA1c, they could see and feel the benefit of a well-controlled diabetes. When requirement for insulin becomes unusually high, it prompts us to seek underlying issue to find out the secondary problems such as non-adherence, incorrect dose, incorrect timing of injection, incorrect technique of injection, or occult infections. A progressive increase in weight should also pull off a warning sign to us. Patients gain weight through conservation of calories ingested, defensive eating due to fear of hypoglycemia, and change in appetite regulation centrally. To overcome this, we could improve insulin sensitivity through diet, lifestyle measures, or use insulin sensitizing OGLDS to avoid the need for large doses of insulin. And with that, I have shared with you 10 most common pitfalls that impede our diabetic patients from achieving their target HbA1c. Hope you have enjoyed my lecture. Thank you very much for listening. Till we meet again. Goodbye.